This briefing will present key statements from the AUA 2026 guidelines on prostate biopsy and risk stratification. We will present the precise language of each guideline for clinical clarity.
The presentation is divided into 4 sections. First, initial patient considerations. Second, the role of MRI. Third, adjunctive diagnostic markers. And fourth, guidance for special cases. We begin with Section 1, Initial Patient Considerations.
Statement 11.
When the risk of clinically significant prostate cancer is sufficiently low based on available clinical, laboratory, and imaging data, clinicians and patients may forego near-term prostate biopsy.
This is a clinical principle.
Statement 12. Clinicians should inform patients undergoing a prostate biopsy that there is a risk of identifying a cancer, with a sufficiently low risk of mortality that could safely be monitored with active surveillance, AS, rather than treated.
This is also a clinical principle.
We now move to Section 2, the role of MRI.
Statement 13.
Clinicians may use magnetic resonance imaging, MRI, prior to initial biopsy to increase the detection of grade group GG2+ prostate cancer.
This is a conditional recommendation. The evidence level is grade A.
For context, PI-RADS stands for the Prostate Imaging Reporting and Data System. It is the standardized scoring system used for multi-parametric MRI to assess the likelihood of clinically significant prostate cancer.
Statement 14. Radiologists should utilize Prostate Imaging Reporting and Data System, PI-RADS, in the reporting of multiparametric magnetic resonance imaging, MP-MRI. This is a moderate recommendation. The evidence level is grade C.
Statement 15.
For biopsy-naive patients who have a suspicious lesion on MRI, clinicians should perform targeted biopsies of the suspicious lesions and may also perform a systematic template biopsy. The recommendation strength is twofold: a moderate recommendation to perform targeted biopsies and a conditional recommendation to also perform a systematic template biopsy. The evidence level is grade C.
This slide clarifies the two approaches. A targeted biopsy samples tissue directly from MRI suspicious lesions, which offers a higher detection rate of significant cancers. In contrast, a systematic biopsy takes samples from predefined regions of the prostate and may detect cancers missed by MRI.
Statement 16.
For patients with both absence of suspicious findings on MRI and elevated risk for GG2+ prostate cancer, clinicians should proceed with a systematic biopsy. This is a moderate recommendation. The evidence level is grade C.
We continue to Section 3, Adjunctive Diagnostic Markers.
Statement 17.
Clinicians may use adjunctive urine or serum markers when further risk stratification would influence the decision regarding whether to proceed with biopsy.
This is a conditional recommendation. The evidence level is grade C.
And finally, Section 4, Guidance for Special Cases.
Statement 18. For patients with a PSA greater than 50 nanograms per milliliter and no clinical concerns for infection or other cause for increased PSA, clinicians may omit a prostate biopsy in cases where biopsy poses significant risk or where the need for prostate cancer treatment is urgent.
This is an expert opinion. That concludes this review of key statements from the AUA 2026 Prostate Biopsy and Risk Stratification Guidelines.